Hello everyone, I'd like to take a moment tonight to go over seizures with you. I've received some feedback in the recent survey you guys took saying that you really enjoyed the ketamine video and really wish that I'd make more videos over each of the protocols, kind of explaining my thought process behind them, and why I made the changes I did. So I would like to go through seizures with you and then kind of give you some research as to why I made the changes I did and then kind of go over the protocol and how I see it used in the field. So without further ado, we can start here with what is a seizure. I think it's important that we lay out what a seizure is. That way we can talk about its treatment later on. So a seizure, as most of you know, are episodes of disordered electrical activity that occur in the brain that can manifest as a variety of abnormal neurological findings. And basically what you have here in the brain, you have two neurotransmitters that are common kind of working against each other or working in tandem to keep this from happening. So you have an MMDA receptor, which is your excitatory transmitter in the brain, and then you have your inhibitory neurotransmitter, which is GABA. And both of these receptors work usually in a check and balance system to keep everyone from having a seizure. It's when these become imbalanced that seizures occur. So you can see this in neurotransmitter levels, receptor sensitivity, ion concentration, or cellular metabolism can cause increased excitation and decreased inhibition, which would lead to a seizure. Now, there's multiple types of seizures here. Most of these are based on EEG findings, which we do not have in the field. They also take the EEG findings along with the level of awareness and motor versus non-motor symptoms, and those three things together really help determine what type of seizures a patient is having. Focal seizures, these are formerly called partial seizures. They involve abnormal activity in one specific originating part of the brain. So you may see someone who's just their arm shakes, and they may or may not have an altered level of consciousness. And then you may see someone that just their right leg shakes. It's just one particular part of the body. And then generalized seizures, this is what's most commonly people are calling 911 for. These are abnormal activity in both hemispheres of the brain, the left and the right, and altered mental status is always present with a generalized seizure. The most common kind we talk about is a tonic-clonic seizure. This was previously referred to as a grand mal seizure. Interestingly, the tonic part is named that way for the muscle stiffness, where people stiffen up and then they usually fall to the ground or have a loss of consciousness with this. And it's followed by the clonic phase, which is the rhythmic and rapid jerking of the extremities. That's how it gets its name. And then status epilepticus, this is for a seizure that is lasting longer than 5 minutes or 2 consecutive seizures without complete recovery of consciousness in between them. Now, please, this exact definition is very imprecise, and even many neurologists don't necessarily agree with this definition, but it's the definition that's most commonly cited. But do know it is up for debate whether that is the true definition of status epilepticus or not. Now let's talk about a little bit of history or kind of things that you may want to obtain on scene. Loss of consciousness is important, but it's not always necessary to diagnose seizures. Like I said before, there may or may not be a loss of consciousness, especially if someone has a partial seizure. But there may be at least an altered mental status with every generalized tonic-clonic seizure. Incontinence, this is what I get asked about. Urinary incontinence is only 38% specific and 57% specific for a seizure versus syncope versus psychogenic non-epileptic seizures. So if you see it, it's only 57% specific. So they may or may not have a seizure. So that makes it can't reliably be used to differentiate between those three conditions. Trauma, someone falls, hits their head, then has a seizure. This interestingly only occurs in about 6% of seizures in the United States, so it's not very common. And then tongue biting. This is one you can use, however. So biting any part of the tongue is only 38% sensitive, but 75% specific. So if someone did bite their tongue, they have a 75% chance that they did have a seizure versus like a psychogenic non-epileptic seizure. And then if someone bites the lateral aspect of their tongue, you may not see it every time because it's only 22% sensitive. However, if you do see it, they without question 100% did have a seizure when you find that physical exam finding. So that may be something you want to look at if you're your next seizure patient. Just want to touch briefly on the postictal phase. This is patients frequently have an altered mental status after the seizure activity ends, and normally these last between 30 and 60 minutes. So you may not fully see them come completely back to consciousness after the seizure, but if they have some comorbidities, then these can last up to several hours. And this is something that we monitor in the emergency department to see how they're improving, because the patient should show continued improvement after the seizure in this postictal phase. So I want to touch here on the changes to the old versus new protocol. And I think this is where the meat is in the talk and what you guys are really asking is why did you take out Valium? And this will be answered a little bit better probably in the studies I'm going to show you in a second. But intramuscular Valium is not recommended for seizures because it's very slow in its absorption and it's very inconsistent in its absorption as well. So while I may give you 10 milligrams and you may absorb it all, your neighbor or friend may not absorb any of it at all, or maybe just 1 milligram, maybe just 2 milligrams that may not terminate their seizure. So there's much better IM medications for emergency termination of seizures, which is what we're most concerned about, is actually terminating the seizure. And for that, we use midazolam. And then the next thing I changed is rapid sequence intubation is no longer required for a seizure lasting longer than 10 minutes. In the previous protocol, if they seized greater than 10 minutes, they needed RSI. That's not the case anymore because not all patients with a seizure lasting longer than 10 minutes need intubation. But you can consider intubation in patients who are actively vomiting or apneic. Otherwise, use BLS airway techniques such as an NPA and a non-rebreather, and you should be able to keep these patients SATs appropriate even if they continue to seize. Now, going back to the IM Versed and why we switched to that. This here is intramuscular versus intravenous therapy for pre-hospital status epilepticus. This is the Rampart trial. And a couple of you that I've talked to have heard me quote this trial. This is in the New England Journal of Medicine. This is probably the best randomized controlled trial done in the pre-hospital setting to date. And what these people looked at in their research was two arms. They looked at IM midazolam versus IV Ativan and the termination time of a seizure. And what they said here, if you look at here, it took them averagely 1.2 minutes to administer IM midazolam, and then 4.8 minutes to get an IV and administer intravenous lorazepam. And then what you saw is once they got this treatment, the people that got IM Versed stopped a seizure in 3.3 minutes, and the people that got IM Ativan stopped their seizure in 1.6 minutes. So what you look at, if you add 1.2 plus 3.3 together, it's a smaller amount of time than 4.8 plus 1.6 minutes, meaning that IM midazolam terminated a seizure faster than the time it takes to get an IV and give lorazepam. Interestingly, they have compared IV midazolam versus IV lorazepam or Ativan, and midazolam's actually faster at terminating the seizure, though it does not have the longest, it has a shorter half-life than IV Ativan. So that's why you'll see people in the hospital going towards IV Ativan because its half-life is longer, though Versed works faster because it crosses the blood-brain barrier faster. Here is a randomized controlled trial of 3 anticonvulsant medications for status epilepticus. This is where you see our addition of Keppra come through, and this is a head-to-head trial for I think it's fosphenytoin, phenytoin, and I can't say the brand or the generic name, levetiracetam of Keppra, so I just call it Keppra. And what this patient looked at, or what this paper looked at, is between those 3 medications, there was no difference in any of them. And so out of all of them, Keppra has the best safety profile. So it is what we use as an additional medication in patients with continued seizure that kind of failed benzodiazepine therapy. Here is, you've seen me add ketamine to that. If you have to call me, this is hot off the press in April of 2025. And this is midazolam and the addition of ketamine for convulsive status epilepticus in the out-of-hospital setting. And what this paper is looking at as people who failed benzodiazepine therapy, the addition of ketamine has been shown to decrease that seizure threshold. And the reason that is ketamine inhibits the NMDA receptor that we talked about originally, while benzodiazepines work on the GABA receptor. So what you have, the longer you continue to seize, the GABA receptors on the cell become less and less and less and less, making your benzos less effective, while the NMDA receptors become more and more and more and more onto the cell, which we believe is the target for ketamine, which we know is the target for ketamine, that has been shown to stop the seizure. So someone that has failed benzodiazepine therapy, they failed Keppra, you can add on the addition of ketamine, and that will hopefully stop your seizure. However, since this is hot off the press, I do make it where you have to call me first prior to the adding on of ketamine so that I can keep track of how much it's being used. And so keep an eye on things and where we're at. This here is the paper looking at the evidence-based guidelines of neurologists that just do epilepsy. So this is the American Epilepsy Society guidelines. And if you Google this paper, they will walk you right through their guidelines, even though they're in the hospital. So some of the treatment you can't do in the field because it all recommends like in-hospital stuff. But it can walk you through what they believe is the best treatments for ongoing status or ongoing seizures in the hospital. I just can't get the PDF into this PowerPoint, so I'm not able to show it to you. But if you Google that title there, you can see their PDF. So let's touch on our protocol here, us and changes I've made. So I've got my other monitor off here to the right where the protocol is a little bit bigger. And so I want to bring up how I expect this to work and how this flows to me. So looking at this, the first thing, if you look over in the upper right-hand corner where it differential, it's always important to keep a wide differential in your mind of what could be causing this seizure. And the first one, the very bottom on that list, is hypoglycemia, which is the one we can intervene on the quickest. So the first thing you should do after looking at the airway to make sure that's okay is to check a glucose. Once you check a glucose, you can treat it here with D10. I prefer D10. That's how I treat all my patients with hypoglycemia. However, if you don't have D10 on your truck, it is appropriate to use D50 if they have a low glucose. And then what I want to next go down to is active seizure activity. So specifically what I want to evaluate for is active bleeding, trauma, eye deviation, if one pupil is larger than the other, mouth or tongue bleeding to see if they've bitten their tongue. That may help differentiate this to it. It may help you work towards a seizure potentially. Urinary or fecal incontinence, lack of arm or leg movement or tone. And if the patient is actively seizing and has been seizing for longer than 5 minutes, then go ahead and treat. Or if they have unstable ABCs, go ahead and treat. But what we do know is a large majority of seizures will self-terminate without treatment in about 2 to 3 minutes. Okay, so even if you look at these guidelines, going back, looking at the neurological guidelines here, looking at this midazolam paper, they did not treat anything unless it was longer than 5 minutes. They didn't treat anything in here in this randomized control trial. And then the Rampart trial didn't treat anybody unless the seizure lasted longer than 5 minutes. So you had to have a seizure at least lasting 5 minutes prior to treating it. So I know that's hard to do, but that is the recommendation of the overseeing bodies. And then first line for me is first determine if you're pregnant or not pregnant. If this is a female and they are indeed pregnant, then they need magnesium sulfate. And so if you have an IV, then you're going to do 4 to 6 grams over 15 to 20 minutes. Now it says maximum single dose of 2 grams. That's correct because a large bolus of magnesium will cause profound hypotension because it is a smooth muscle relaxer, which is why you see us use it in COPD or asthma. So if you were to dose somebody a full 6 grams at one time, they will have profound hypotension if given IV. So you give it 2 grams at a time for a max of 6. And then if you don't have an IV or you don't have an IO, then you can move to IM, magnesium sulfate, at 5 grams. Now, Chris Ballard brought it up to me that our concentration of magnesium is quite a lot, and you couldn't put all of 5 grams into one single syringe and give it. It would be like 10 mLs or something. So what we decided to do, since that is our concentration right now, that could change, but since that is our concentration right now, you're probably going to break that up into multiple IM shots. So probably 2 or 1 in the hip on each hip, and potentially 1 in the thigh on each thigh, and then into the deltoids bilaterally in order for them to get that total of 10 grams. And then once you have that, you move on to your benzodiazepines. Now, this seems to be where some of the questions have come up when people have talked to me in looking at your IO IV access. If you don't have IO or IV access, you need to move towards IM medications if the patient's been seizing longer than 5 minutes. And unequivocally, the drug to use is IM midazolam, okay, or Versed. And that dose is 0.2 milligrams per kilogram up to an initial single dose of 5 milligrams. And then you can repeat that in 5 minutes if they continue to seize. Or you can give it intranasally, but you can only put 1 ml into each nostril. Okay, where the questions come up is about Ativan. Now, this isn't pick one and then use all it up, then move to Ativan. That's not the case. Choose either if you're going IM, I would highly recommend that you choose midazolam. But for some odd reason you want to use Ativan because they're allergic, that's fine, but stick to that drug. So let's say, for instance, you give them IV or you give them IM midazolam, they stop seizing, you're able to get an IV, then stick with IV midazolam to stop the seizure. Don't go IM Versed, and then when you get an IV, give them IV Ativan. That's not the case. You choose one or the other. Okay, I notice here first line, I recommend that you choose Versed either way, whether you're given an IM or given an IV. However, if something happens, they're allergic, or we just for some odd reason you don't have IV Versed, we're out of stock or something, you can use IM Ativan and then give IV Ativan as well if you need to. Now, if the patient continues to seize longer than 5 minutes and you've given your benzo, it's safe to go ahead and add on your Keppra. Okay, so 60 milligrams per kilogram, IV or IO. This is not an IM medication. And then you give it over 5 to 15 minutes, and it says our dose is 1,500 milligrams. I think we are only carrying 1,000 milligrams in the truck. I don't think we're carrying 1,500. So if you only got 1,000, just give them 1,000. Give them whatever you have in the truck, up to 1,500 milligrams. Now, if you read the papers, you will see that it's 60 milligrams per kilogram up to 4.5 grams. That is true. We just don't have the room nor the transport time to administer 4.5 grams of IV Keppra. We don't have the patients long enough. Now, if they do continue to seize 10 minutes and you've given the medications above, call me and we will likely give them ketamine to hopefully stop the seizure. In febrile seizing infants, that's something that come up, and it is coming about that time of the year where we may need to do that. We don't have the ability to give rectal Tylenol here because it will melt and you can't really dose it properly by the weight because there's not scores on rectal Tylenol. So what I recommend now is just remove, first of all, take them all out of the clothes because inevitably they're just bundled from head to toe. So take them all out of their clothes and kind of get them naked. Lay them on the stretcher and then you can put ice packs to their axilla and chest and then monitor the patient. If they still seize longer than 5 minutes, then move on to your normal seizure pathway of IM or IV benzodiazepines appropriate for their weight. Inherently, though, when you take them out of the clothes and cool them down, they'll stop seizing if it is a febrile seizure. In regard, just a piece of information on a febrile seizure, it's how fast the temperature rises that causes the seizure, not so much what the maximum temperature is. The inverse of that's also true. If you cool them too quickly, they will seize again as well. So don't get carried away with shoving ice all over these people and trying to rapidly cool them because they're likely going to seize again. And then one note down here in the bottom in the lower left-hand corner, the total dose of midazolam is 10 milligrams. So whether you give 5 and you give another 5 IM, that's the total dose is 10 milligrams. So if you have to give more than that or you think you need to give more than that, call me because we need to think of something different before we start trying to treat that. Okay. Hope that answers all your questions. Please feel free to reach out to me. My phone's always on, call, text, email, whatever you need to do. And if you have any more questions, please just don't hesitate to reach out. Thank you and have a great day.